Alrighty, it's Cass here, and today we're going to be going over bipolar and related disorders. So this affects 4.4% of the population. Its onset is around early 20s to like before you're 30, and it causes extreme depression to mania, which are two wildly different emotional states. So we have bipolar 1 disorder, which is the most severe form. Um, it has the highest mortality rate, and there's at least one manic episode. Bipolar 2 disorder, which has at least one hypomanic episode and at least one major depressive episode. And then cyclothymic disorder, which is alternate hypomania with symptoms of mild to moderate depression for at least 2 years in adults. So hypomania. So this is euphoria. It can increase function, and it's not as obvious as mania. So manic episodes are feeling of euphoria and elation, or anger and irritability with a labile mood, impulsive high-risk behavior, increased activity and aggressive behavior, increased energy and rapid speech, decreased sleep and nutritional intake, difficulty concentrating, disorganized thoughts, fleeting grandiose ideas such as, oh, I'm the Queen of England or I'm Jesus. Lack of, or the next Messiah, I guess would be a better way to put it. Lack of insight about illness and consequences of behavior, inflated self-esteem, and delusions and hallucinations in severe cases. So, in bipolar 1, this lasts at least 1 week. It's a sudden onset. It can be a psychiatric emergency with a labile mood, short-lived aggression, pressured speech, unlikely to pause, exaggerated self-importance, and poor insight. So, hypomania is a low-level and less dramatic mania, which tends to be euphoric and often increases functioning, and it's accompanied by excessive activity and energy. It's not severe enough to impair functioning. It's not usually hospitalized. So the assessment for bipolar disorder is their mood. Are they like happy, joyful, enthusiastic, friendly, that then quickly changes to irritation and anger? Behavior, are they constantly active, reduced sleep, decreased eating? Are they scheming? Are they doing spending sprees, distractible, hyperactive, unusual, bizarre, colorful, or inappropriate dress? Are they sexually promiscuous? Are they hyper-focused on socialization? What about their thought processes? Do they have pressured, circumstantial, tangential speech, loose associations, flow of ideas, clang associations? So pressured speech is every word has a lot of emphasis. There we go. Circumstantial is off topic, but we'll get back to the topic eventually. Tangential is off topic and never will get back to the topic. Loose associations jump from topic to topic with minimal connections. Flight of ideas, rapid speech, topic jumping, and minimal focus. Clang associations, rhyming but makes no sense. So, I'm the queen, I'm the scene, I don't know. And then thought contact, grandiose delusions. Do they think they're the Queen of England? And then persecutory delusions. Do they think there's people after them when there's no one after them? Do you think there's cameras in every room? Is the government watching them? Kind of a thing. So, you want to look at physical symptoms as well before you jump straight to bipolar, because hyperthyroidism, brain tumors, strokes, stimulant-type drugs, and neurotoxins can cause mania-like behavior. You need to assess, are they a danger to their self or others? Do they need protection from uninhibited behaviors? Do they need hospitalization? What's their medical status? Other medical conditions that they have? What about their patient and family understanding? Like, do they understand anything about the disorder, about the medications, how they're supposed to adhere to the medications, if they need support groups or organizations? And so problems related to risk to manic episodes. Sorry, that was a very quick topic jump. Risk for injury, risk for violence, sleep deprivation, impaired cognition, impaired concentration, self-care deficit, so feeding, bathing, dressing, imbalanced nutrition, impaired socialization. So interventions for manic episodes include it needs to be very structured because they have like chaos going on in their own body. Communication, you need to be firm, calm, with short and concise explanations, with a consistency, relay your expectations, listen, and redirect behavior to appropriate behaviors. Structure, low stimulus environment, scheduled or structured schedule, medication, seclusion, restraint if necessary. Keep valuables in a secure place. Nutrition, do they need INO, vital sign monitoring, frequent high calorie protein fluids and finger foods, and they need reminders to eat. Sleep, encouraging to rest during the day, for periods during the day, and promote relaxation because they're not getting a lot of sleep at night. Hygiene, encourage appropriate dress, which is like, is it cold out, put a sweatshirt on instead of a tank top. And if they like people can dress how they want, but like if they're putting like 3 skirts on over each other and like a tiny little tank top or something like that, maybe like be like, hey, like, do we have another shirt we can put on? I don't know. I just know like a lot of the times with mania, you want it to be calm, and if their dress is not calm, that can be a constant reminder because you can look down and see it. Hygiene, so, and then elimination, so high fiber fluids and laxatives if needed, again, like the depression, which is interesting. So patient family education includes knowing that it's a chronic illness, long-term medication is required, the side effects of the medication, warning signs of impending episodes, maintaining regular sleep patterns, meals, exercise, etc., and then support groups. And so now we're on to medication for bipolar, which is lithium, which is a, I believe, a third level treatment. So it's a mood stabilizer, acute mania, and maintenance therapy. The therapeutic levels are 0.6 to 0.8 milliequivalents per liter of blood. So you're going to be wanting to draw those labs at least 8 hours after administering lithium, because if you draw it right after you administer, it's going to be like a lot higher than it actually is. So when you're beginning lithium, you get labs 2 to 3 days before, or every 2 to 3 days, and then after any dosage change, and then 3 to 6 months. And the side effects are nausea, vomiting, diarrhea, thirst, polyuria, which is producing too much urine, lethargy, sedation, and fine hand tremor, renal toxicity, goiter, hypothyroidism, and those 3 may occur with long-term use. So lithium toxicity, early signs of toxicity are GI upset, coarse hand tremors, which are going to be like, yeah, I think like that, confusion, hyperirritability of muscles, EEG changes, so electroencephalographic changes, sedation, incoordination, so you want to withhold the lithium, dosage reevaluated after you draw labs. So advanced signs of toxicity are ataxia, giddiness, serious EEG changes, blurred vision, clonic movements, large output of dilute urine, seizures, stupor, severe hypotension, coma. Death is usually secondary to pulmonary complications. So hospitalization is indicated, the drug is stopped, and excretion is hastened. So that can include a whole bowel irrigation. Fun. And then severe toxicity is convulsions, producing no urine, and death. And then, so in addition to the interventions I just mentioned for advanced, you're going to also maybe want to do hemodialysis, which is what a lot of people do for kidneys. So you'd be taking the lithium out of the blood. So family teaching for this is keep taking the medication even once the manic episode subsides. Frequency of lithium level monitoring, annual renal and thyroid labs. You want at least like 1,500 to 3,000 milliliters of fluid a day. You want like a normal sodium intake. You can't, if you have too much sodium, there's no therapeutic effect. Too little can cause lithium toxicity. So this is not indicated for people with low salt or salt-free diets. You're going to want to avoid diuretics, which can increase the risk of lithium toxicity. No over-the-counter medications. You want to take it with a meal. You want to tell them the side effects, signs of toxicity, and what to report, and don't abruptly stop taking. So anticonvulsants, we have Depakote, Equetro, and Lamictal. So these are effective for continuously cycling patients, so depression mania kind of thing. Reduces impulsive and aggressive behavior in non-psychotic patients, help controls the mania and depression. And so it reduces the aggressive behavior, and it's approved for acute mania and bipolar as a mood stabilizer. So for bipolar depression, you want to use Latuda, Seroquel, Verilur, and Cymbaxa, which is a combination of Zyprexa and Prozac. And then for acute mania, you want to use Zyprexa, Risperdal, Seroquel, Geodone, Abilify, Sapphirus, and it's like Vraylar. And so anxiolytics, benzodiazepines are Klonopin and Ativan. So these can treatment of acute mania symptoms, agitation, aggression, panic, and insomnia, but these are only for short-term use. And so that is all that I have for you today. And so I will see you next time. Bye!